and she's from Alor as well. Graduated from USM in year 2000 and passed her masters in 2010, and she is currently a trainee for gynaecology program at Hospital Sultanah Bahiyah. Without further ado, Dr. Mazni.
Assalamualaikum and a very good morning. Thank you, Dr. Kaur, Mr. Chairman. I would like to thank the AJKs for inviting me to share this lecture with all of you. Thank you for being with us on this precious Saturday. This is a weekend. So I hope the sharings today will be of benefits to everyone. So I will be talking on the management of abnormal cervical smears. So basically, this is a fight for everyone. This is a fight for us against cervical cancer. Our aim is basically to eliminate cervical cancer from the world. But currently, cervical cancer is still the fourth most common cancer worldwide. Numbers of new cases are many. The deaths are also many. And basically, this is the disease of poorer countries. But the unique part of this cervical cancer is that it is actually preventable. If it's detected early or if it's detected at a pre-cancerous stage, it is definitely treatable. It has a slow progression from pre-cancerous stage to invasive stage. That is why it is a very unique disease and is definitely preventable, provided we have a effective screening and treatment. It is a cancer in which it is has a cytologically identifiable precursors, and it has a very effective screening method. That is our Pap Smear. We do not want to see the cervix when it is at this stage. We want to catch the people at the pre-cancerous stage. That is why we do screening. What about Malaysian situation? It is actually the third most common cancer in Malaysia. Unfortunately, 76% of patients detected at stage 2 and above is quite late. Therefore, screening is very important. We have started Pap Smear screening started in 1969. It goes long way before. But unfortunately, the coverage is only 26% detected in 1996. In 2007, is only about 43.7%. I know all of us are working very hard to increase this coverage of Pap Smear screening. So hoping that in future, with a comprehensive program that we have and involvement of many the Ministry of Health, involvement of the NGOs, the universities, we will definitely can be able to increase our cervical screening capture. So in Malaysia, we have many organizations basically providing cervical screening services. So what are the screening options that we have? Basically, we have cytology based. That is our previous conventional Pap Smear. This is how our Pap Smear screening started. Eventually, we move on to our liquid-based cytology. Currently, I think available in most of the klinik kesihatan. We are moving towards HPV DNA test. As you all know, the Association of Cervical Cancer and Human Papillomavirus is known. About 70 to 80% of cervical cancer is caused by this human papillomavirus. So therefore, this HPV test is of beneficial in few, especially if we can incorporate this HPV test into primary cervical cancer screening. We already have the framework. We already started basically a pilot study last year involving 4 states in Malaysia, and we are waiting for the results. And we hope in future we can really apply and incorporate this test into primary cervical cancer screening. Basically, the guideline is already out and produced by the Bahagian Perkembangan Wanita MOH. What are the target groups? we are targeting all sexually active women ages 30 to 65 years old. But those who are younger than 30 years, they are encouraged to come for screening as well. What are the screening intervals? Yearly for 2 years, then 3 yearly if normal. But if we have the opportunity to have the HPV test as well, and cytology and HPV were both negative, the screening interval can be lengthened to 5 yearly. Okay, I'm not going to show you how Pap smear is done. It's just some slides to show a few aspects of Pap smear. This is a cervical smear using cervical sampler broom. This is how they apply the smear on the slides. Okay, they fix the slide. This is transferring the sample, the cervical smear samples, into vial containing preservative in a liquid-based cytology smear. Okay, how do they report Pap smear? How do you read the Pap smear reporting? Basically, we use Bethesda reporting system 2014. They will mention whether the specimen is a conventional smear or is it liquid based, and of course they will comment on the adequacy of the specimen. Okay, on the adequacy of the specimen, it will be mentioned whether the specimen is satisfactory for evaluation or unsatisfactory. So it will describe the presence or absence of endocervical or transformation zone, or any other quality indicators such as blood obscuring or inflammation. So there are many reasons for unsatisfactory evaluation, and it will be specified in the Pap smear report. Okay, when the smear is normal, it will be mentioned as negative for intraepithelial lesion or malignancy. The common abbreviation is NILM. This is defined when there is no cellular evidence of neoplasia. This is stated in general categorization above, and whether or not there are presence of organism or other non-neoplastic findings. Okay, what about other abnormalities? We can divide the abnormalities into two, basically squamous cell abnormalities or glandular cells abnormalities. Okay. So these are the common abbreviations that you will see in a Pap smear report. So if it's squamous cell abnormalities, it can be atypical squamous cells, either undetermined significance, or we normally call it ASCUS, or cannot exclude high cell, high grade lesion, ASCH. So within these two, you have to be very clear. Okay. There is also low-grade squamous intraepithelial lesion, or I will mention as low cell. High-grade squamous intraepithelial lesion or high cell. This will also include CIS, CIN2, CIN3, or features suspicious of invasion. CIS is carcinoma in situ. CIN is cervical intraepithelial neoplasia. And the extreme end of it is, of course, squamous cell carcinoma, the invasive stage. The second one is the glandular cell abnormalities. It will be described as either atypical, endocervical, endometrial, or glandular, NOS, or specified in comments, or atypical, endocervical, glandular, favor neoplastic, or endocervical adenocarcinoma in situ, or adenocarcinoma. Okay. How do we manage this abnormal cervical smears? Basically, when you look at the abbreviations, they will make you confused. But please, it is very simple if you can follow what I'm going to tell you later. I will try to simplify so that it will not cause confusions to the managing doctors as well as the paramedics in klinik kesihatan. Okay. Some smears will be reported as unsatisfactory. So if the Pap smear is unsatisfactory for evaluation, we can repeat the smear within 3 months. If it is normal, then we follow routine screening schedule. Okay, all these flowcharts are taken from this guidebook for cervical cancer screening, the latest version 2019. Okay, so If the second smear is also unsatisfactory, then call us for colposcopy. If the smear repeated is not normal, basically NILM, then we can refer the flowchart for management of NILM, in which I will show you later. Okay, I know the chart is very small. I will explain each and every compartments later, because this is very small. I don't think anybody can see. This is the flow chart when the report is negative for intraepithelial lesion. Okay, if NILM and the result is normal, we should follow routine screening schedule. If it is atrophic, we also follow routine screening schedule. If it is reported as no endocervical or transformation zone cell seen, you shall repeat the smear in 1 year. Okay. If in the report of Pap Smear NILM with specific microorganism identified, we have to treat appropriately and repeat the smear after 4 to 6 weeks after the treatment. If normal, then follow routine screening. If persistent, then this is the time to refer to gynae or at least to the family medicine specialist. Next, if the smear reported as inflammatory changes, then we can either treat the infection or the atrophy, and also we repeat the smear after 4 to 6 week treatment. 4 to 6 weeks after treatment. If it's normal, again we follow the routine screening. If the second smear have similar changes, then we refer to gynae or FMS as well. What if the smear reported as endometrial cell seen in women 45 years and above? Then we have to correlate clinically with clinical findings, age, hormonal status, as well as menstrual test status. Basically, we need to clarify further. Therefore, you have to refer to gynecologist. Okay. What about squamous cell abnormalities or atypical squamous cell? If the report is atypical squamous cell and it is unable to exclude high-grade lesion, ASCH, then this is the time for you to refer to us for colposcopy. Okay. If the smear reported as ascus, then if we have Hpv test, that is very beneficial because we can basically identify which is at higher risk. So, if HPV test is available, HPV positive, definitely we have to refer for colposcopy. If HPV negative, repeat HPV testing in 12 more months. Negative, 5 years screening, 5 years re-screening. If positive, then colposcopy. If HPV test is not available, then we can repeat the smear in 6 months. But most of the time in Bahiyah, if you refer for ascus, we will still accept the referral for colposcopy. It's just that the appointment date will be given later. This is when it becomes controversy, because when the doctor in klinik kesihatan inform the patient you have abnormal smear and probably they interpret that as cancer, then the patient will go havoc, keep calling us for earlier appointment. So for now, I think you have to assure your patient this is ascus. It is safe to repeat smear in 6 months. And if you were to go for colposcopy, it's not that urgent. If we can give a later date. Okay. What about low-grade squamous intraepithelial lesion? For low-grade squamous intraepithelial lesion, there are questions to ask before we go to the flowchart. Okay. We have assessment of risk factor and presence of at least one criteria will put the patient into the group who has to go for colposcopy. Okay, the criteria are age more than 30, patients who are known to have poor compliance to treatment and follow-up, to those who are immunocompromised, patients who are symptomatic, always having abnormal postcoital bleeding or frequent infection or discharge, then they are considered symptomatic. Or patients who have history of pre-invasive lesion before, and patients who are positive for high-risk HPV. So for this patient, If any of the factor is positive or present, then refer for colposcopy. If there is no risk factor, we can divide into either whether Hpv test is available or not. If Hpv test is not available, then we can repeat smear in after 6 months. Then treat accordingly. NILM, then you go to the flow chart of NILM. If ascus, that means she has twice abnormal smear, low seal and ascus, then of course refer for colposcopy. If Hpv test is available and Hpv is negative, then you can repeat Hpv test in 1 year. If positive, of course, refer for colposcopy. Negative for HPV, resume a routine scheduled screening. So for low seal, there are risk factors that has to be asked. Okay. What about high-grade squamous intraepithelial lesion? So of course, when it is high seal, either high seal or suspicious for invasion, or of course if it's the extreme end of squamous cell carcinoma, refer for colposcopy, and of course refer for gynecological oncologist if it's a cancer. What about atypical glandular cell, that is glandular cells abnormalities? So atypical glandular cell NOS, atypical glandular cell favor neoplastic, all has to be referred for colposcopy, and also endocervical sampling, that is to refer to us. And of course adenocarcinoma in situ and adenocarcinoma, of course refer to gynecology oncologist for further management. So we will not elaborate further on that. So it is quite simple in glandular cells abnormalities. And of course, if it's already endocervical adenocarcinoma in situ, adenocarcinoma, so this is definitely abnormal, need to be referred for colposcopy, endocervical curettage, and also endometrial sampling, that is to refer to us. Okay, management of women aged more than 45 years and above with endometrial cells presence undergoing Pap smear. Of course, the history and everything has to be taken into considerations. If there is no cervical epithelial abnormalities, perform an endometrial biopsy. If there is cervical epithelial abnormalities, endometrial biopsy and manage as cervical epithelial abnormalities as per guideline. The colposcopy. Okay. So this is if we have HPV test available. So how do we manage HPV results following HPV DNA testing? Okay, this is primary HPV testings for cervical cancer screening. This is the guideline which we already have. It's just that it has not been put into implementation yet. We are hoping so much that it will come to us very near soon. Okay. If HPV not detected, therefore repeat HPV test after 5 years. That is very convenient for everyone. Okay. If oncogenic HPV positive but not 16 and 18, I want to inform you, to those who do not know, oncogenic HPV 16 and 18, 70 to 80% will cause cervical cancer. That is why we are so concerned about these numbers. There are a few other numbers, but I think you remember this 16 and 18 should be enough. Okay. If it's positive but not 16, 18, proceed with liquid-based cytology. If unsatisfactory, repeat liquid-based cytology in 6 to 12 weeks. If negative, can repeat HPV in 1 year. If it is reported as squamous cell abnormalities, then refer for colposcopy. And if it is of course cancerous, then you refer to gynecological oncologist. If oncogenic HPV positive and that is 16 and 18, of course we proceed with liquid-based cytology and colposcopy immediately. If the HPV test is unsatisfactory, then we repeat HPV test within 12 weeks. Okay. Do not have to memorize this. Is available in the Hpv Testing Cervical Cancer Screening in Malaysia. That is also by the Bahagian Perkembangan Wanita produced last year. Okay. What about patients who have had hysterectomy? Do we need to follow them up with Pap Smear? Okay. If the hysterectomy is for benign disease, normal Pap Smear history, histopathology of the cervix is known and is benign with no dysplastic neoplastic changes, they may not require any further screening. If it was subtotal hysterectomy, I lost the part, the initial part. Subtotal hysterectomy means the uterus is removed but cervix is left behind. We have done that for certain situations. So for this patient, they should continue to have Pap Smear according to normal screening schedule. And if you know that this patient have had hysterectomy before, where the etiology is not known, whether it's benign, whether it's precancer, so they should have one baseline Pap Smear. If this is normal, then further screening should be based on clinical indications. What about patients who are immunosuppressed? They should continue to have Pap Smear at yearly intervals. Those women with past history of CIN 2 and 3, if the excision margin was involved or histological assessment is inadequate, therefore follow-up should be at a gynaecologist. So they will be under our follow-up. If CIN 2 and 3 completely excised at hysterectomy regardless of margin, Pap Smear yearly for 5 years followed by 2 yearly smears. And of course, women who was previously treated for invasive gynecological malignancy will be followed up by gynecological oncologist. Okay, what about abnormal Pap Smear in pregnancy? So for abnormal Pap Smear in pregnancy, colposcopic examination has to be done basically to exclude invasion. If suspected high-grade lesion, biopsy is indicated. If the histopathology is CIN 2 and 3, that means high-grade lesion, colposcopy for every trimester has to be done to rule out progression to invasive disease. If there is no progression, treatment of CIN should be deferred until patient delivered and 6 weeks postpartum. So, there is a list of indication for colposcopy. Basically, suspicious looking cervix. If it's very suspicious, I would suggest that you can call us direct so that we can give earliest appointment so that we can biopsy the lesion. If unexplained postcoital bleed or blood stain vaginal discharge and postmenopausal bleed, persistent unsatisfactory smears, persistent inflammatory smears, persistent ascus or ASCH, ascus positive for high-risk HPV or ASCH. Some more, persistent low seal with high-risk factors as I have already mentioned earlier, high seal, SCC, AGC, adeno-CA, and of course positive for high-risk HPV. Basically, this is a repetition from the previous flow charts. Okay, this is the ideal recommended waiting time for colposcopy appointment following Pap Smear report. That is why when you ask for appointment, it is very important to give the diagnosis correctly. So if it is ASCH or AGC, recommended standard waiting time is about 6 weeks. High seal, 4 weeks. Suspicious of carcinoma, 2 weeks. First time referral with other reason within 12 weeks. So give a clear indication for us, then we will give the appointment accordingly. Even if you ask for ascus also, we will do, but the appointment will be later. So just a picture showing how colposcopy is performed. Basically, this is an outpatient procedure. Patient does not require any anesthesia. So we will use our microscope and stain with some solutions to look at the abnormalities. So at least you can give some ideas to the patient what they are expected, what is expected when they come for colposcopy. So what are the management of pre-invasive disease of cervix? Basically, I'm talking about histopathology of CIN, cervical intraepithelial neoplasia. Basically, we have two. Either we ablate or we excise. So these are all. We have cryo, we have electrodytomy. For excisional, we have LEDs or lip, laser conization, and cold knife cone biopsy. So I I'm short of time. Okay, all right. So this is a diagram of lip. How do we do it? This is also an outpatient procedure. So this is cone biopsy, in which we remove some parts of the transformation zone. This is done in under general anesthesia in OT. This is our cryotherapy. Okay, I want just some information on primary HPV testing. This is the front page of the guidelines, which I mentioned earlier, produced last year. So the association of cervical cancer and human papillomavirus is very true. Basically, it's just a rare outcome of unresolved HPV infection. But from pre-invasive lesion to become invasive lesion, it is 10 to 20 years. So this is the time when we want to catch these people at pre-cancerous stage. So why HPV testing? There are a few indications, and for this we are looking at HPV as primary screening based on the flowchart earlier. So target group similar, 30 to 49, less than 30 advice, less than 30 and 50 to 65 advice for Pap Smear screening. Intervals is very good because it will be 5 years if you are tested HPV negative. Sampling, self-sampling devices. There are in the guideline they give you the general guide for self-sampling technique, and this is how they report whether HPV detected, not detected, non-1618 or 1618. So again, this is the repetition of the first flowchart, so I will not repeat. You can just go and refer to it when indicated. So once a woman is sick, then therefore it gives implications to the family, to the economy, to the financial and everything. So we don't want to catch these people when they have squamous cancer of cervix. They are going to live with nephrostomy, and eventually they will leave the family. Okay, this is the guidebook for cervical cancer 2019, which has been my reference. This is definitely abnormal cervical cancer. So if you see this, call us. So this is WHO Global Elimination Strategy through vaccination, screening and treatment. So we have a very good school HPV vaccination program, so that is recognized worldwide. Okay, this is what we want to achieve in 2030. 90% fully vaccinated by the age of 15, 70% screened by the age of 35, and again by the age of 45. 90% with cervical disease receive treatment. 90% with pre-cancer and 90% with invasive cancer. A long way to go, but I think it's doable. So it is left to us to work for it. Thank you.
Okay, thank you, Dr. Mazni. We have 3 questions from the participants.
Okay.
The first question is from Nurul Abdul Manap. Assalamualaikum, Dr. Mazni.
Waalaikumsalam.
I would like to ask, if patient initially come to GP for Pap Smear and on speculum examination, we observe a vaginal discharge.
Okay.
Should we abandon the Pap Smear and go for HBS, CNS and give pessary? Or should we just continue taking the Pap Smear?
You can just clean the discharge and proceed with Pap Smear. And if you want to treat empirically, you are talking about GP kan, you can treat empirically, but it is not contraindicated for doing Pap Smear at that time. Okay.
Okay, the second and third question are quite similar from Yati and also Nurul Abdul Manap as well. Assalamualaikum, Dr. Mazni.
Waalaikumsalam.
I'm from LPP KN, where HPV testing is available.
Okay.
The thing is, it is very patient oriented. Thus, the rate of unsatisfactory sample is higher from the regular conventional Pap Smear.
Okay.
Do you have any true statistic regarding this? And then from Nurul, how about the percentage of the detecting the changes comparing the cytology or the HPV testing?
Again, the second question.
The second question is,
what is the
which investigation will be more convenient to the patient if they were given options, cytology testing or HPV test? And do you have any statistic on this?
Okay, the second question first. If we have cytology only, that means Pap Smear, and you have the HPV test, I think you do both, because according to the because according to the flow chart, if you have both, then the discriminating in the result is better. I think you can. Okay, I want to show you the. Okay, if you have Hpv testing and you have liquid-based cytology. Okay, let's say if Hpv test, you do both. Yeah, Hpv test came back as positive non-16-18, and you have the liquid-based cytology result. So let's say the result is C, then you can straight away proceed for coposcopy. You don't have to do one after another. So this is in the flow chart. So it is beneficial. So the second question was, what was the
HPV testing is very patient oriented.
I think because it's a self-sampling kan. Betul. Okay, as I mentioned earlier, last year we have had a so-called pilot study involving 4 states in Malaysia, in which we were given the cervical sampler to patients. But unfortunately for Malaysian statistic, we are still waiting for the data from that study. It is not yet out. So I understand the self-sampling for cervical smear and self-sampling, there will definitely be differences. But if you were to, I would prefer cervical sampling because patient will have more compliance and they will more will come forward if it's a cervical sampling. What we can do is to avoid all these unsatisfactory smears is education to the patient.
Okay, last question, Dr. Mazni from Nur Hafila.
Okay.
Assalamualaikum, Dr. Mazni.
Waalaikumsalam.
Can we suggest or offer HPV vaccine in a pre-cancerous lesion? Or if can, what we can suggest, the Gardasil or Cervix?
I don't want to answer for the Gardasil or Cervix, but for pre-cancerous lesion, once they are treated, then we can offer HPV vaccination. So if it's let's say CRN3, you have done coposcopy, then treated, then it's not contraindication for HPV vaccination.
Okay, thank you very much.
Okay. Thank you very much.
Okay, thank you very much, Dr. Mazni, for the informative talk.